So it's just a little bit of an overview of what the session will look like today. So I'll spend some time talking about the work that Healthy Aging Alberta has done over the past year. And then we'll get to hear from the regional projects. So Krista from Edmonton, Megan from Calgary, and then Heather from Lethbridge. Those were our phase 1 communities. And then we'll also hear from Ruth from Vulcan and Dixie from Innisfail in regards to some of our phase 2 work that we're doing. And I wanted to start today. Shoot, I'm going to have to stop sharing my slides and reshare because we've just developed a video and I think it'll really set some good context for the rest of the webinar. Okay. Someone let me know in the chat if this for some reason does not work.
Social prescribing is a holistic approach to health that bridges the gap between medical and community social care services. Did you know that over 80% of a person's health depends on social determinants like adequate food, housing, income, and relationships with others? Through social prescribing, healthcare professionals can refer patients to community-based programs to improve their overall health and enhance their quality of life. Meet George. He has diabetes and has been visiting his doctor more regularly with anxiety concerns. George thinks his anxiety is related to his diabetes. But his doctor recognizes instability in George's personal life, which could be the main cause of his anxiety. The doctor discussed this with George and then made a social prescription to refer him to a link worker. A link worker is a non-clinical professional. This individual is employed by a community-based organization that focuses on serving seniors. Link workers build relationships with older adults and monitor their progress. The link worker assigned to George helped him to develop key health and social goals. They discovered that housing and food instability were causing George's anxiety and worsening his diabetes. Together, they determined which community programs and resources would best meet his needs. Together, they created a care plan and worked at a comfortable pace for George. The link worker also checked in on him regularly and sent progress updates to his family doctor. With assistance from the link worker, George accessed a housing subsidy and was referred to the food bank. He also received transportation support in his community so he can participate in social and recreational programs. There are many benefits of social prescribing. Improved physical and mental health. Increased confidence to live at home. Reduced isolation and loneliness. Reduced length and frequency of hospital stays. And increased community connections and natural support networks.
Awesome. Hopefully that worked for everyone. Every time I click on something to check the chat, it paused the video. So I apologize for that. So the next thing I wanted to just take a look at was this infographic that we've recently developed around the social prescribing pathway. And so this really captures the approach that we're taking with social prescribing here in Alberta. And so on the left side of the screen there, we've got healthcare providers. And as we just learned through the video, healthcare providers are the individuals that are making that social prescription. And so when we say healthcare providers, we really mean any regulated healthcare professional is able to make that social prescription. And so that could be a family doctor, it could be a nurse practitioner, could also be a pharmacist, in some cases, community paramedics. And our projects have been focusing on 3 different areas of healthcare. So primary care, also hospital discharge with transition coordinators, and then also home care with home care case managers. So those are the 3 areas of the healthcare system that we've been focusing on, kind of building awareness of social prescribing and then receiving referrals from. So then that referrals I then received by a link worker or an equivalent role in the community. That link worker is meant to bridge the gap between healthcare and all of those aging and community supports that we know exist in community-based senior serving organizations. So the link worker will do a more holistic assessment with the older adult. They'll co-create goals and a care plan, engage in regular follow-up and support, And then when appropriate, provide progress updates back to the healthcare provider that made the initial social prescription. And so the aging and community supports, that's all of the things that the older adult would be connected to based on their goals and their care plan that they've co-created with the link worker. And so that could be a range of things. Could be support with meal preparation and food security. It could be access to in-home supports like light housekeeping, yard maintenance, snow removal. Could be assistance accessing different financial benefits that people are eligible for. Be transportation support, service navigation, and then the big one would be all of those social and recreational programs that exist in communities like coffee clubs and line dancing and men's sheds and all of those different programs and activities that really support health and well-being. And then the other piece there is more around case management support, and that's for more of those complex needs that might require some of those social work interventions that are out of scope for that link worker role. So all of our regional projects align to these 8 provincial principles that we've established for social prescribing. And so we recognize that social prescribing requires a formal pathway to connect clinical care to community-based services. One of the things that we commonly hear is that we already do this and we've been doing this for years. And we're like, absolutely, yes, you have. But it probably hasn't been done in a formal and intentional way so that we can really collect data on the impact of those community-based services on someone's health and well-being. And so social prescribing is really about having that formal connection between clinical care and community-based services to build out and support evidence for the role of community-based services. The second principle there is that social prescribing begins with an identifier. That person is considered a clinical professional. So that's all of the regulated healthcare professionals that were shown in that infographic slide. That clinical professional identifies that someone has a non-medical health-related social need and makes the social prescription, which is then received by a non-clinical professional. And so this principle is really highlighting the fact that, people are working within their expertise and their scope of practice. Healthcare practitioners were trained to provide medical services, and they shouldn't be expected to know the hundreds and thousands of programs and services that exist in community that could address more of the social needs. So we strongly believe that community-based professionals are best positioned to have the knowledge and understanding of what is best required to kind of meet those non-medical needs. Social prescribing is also a holistic, person-centered approach. And so we recognize that clients may have complex needs, but they also have unique goals, passions, and gifts as well that they can contribute. And it's strength-based, so clients are encouraged and supported to share those gifts through participation in the community where they can. Social prescribing is co-creative. It's really about older adults working in partnership with providers, whether that's their healthcare provider or their link worker, to design a care plan that really meets their needs and utilizes their strengths as well. And then they're supported in implementing that plan. Number 6 there is that social prescribing is community-led. It's really about building individual and community resilience by supporting clients to become more connected in their communities. It's not a one-size-fits-all approach. So we recognize that some clients may require more support from a link worker to address multiple goals than others. And then the final one there is that social prescribing is rooted in health equity. And what we mean by that is that effective social prescribing has to include working with clients to remove barriers that they may face to accessing certain programs and services that impact their health and well-being. So this is the more exciting stuff. So we started this work with 3 communities in December of 2022. And so those were our phase 1 communities. So Calgary, Edmonton, and Lethbridge. And these communities were selected because there was already some existing momentum around social prescribing that we wanted to build on and develop. And so in the past year, healthcare providers in those 3 communities, they made 704 social prescriptions. And out of those social prescriptions that have been made, 581 older adults have worked collaboratively with a link worker or an equivalent role to co-create their goal plans. And so the difference in those numbers comes from a few reasons. Some of the social prescriptions that were made were maybe not appropriate. So they might have been for clients that had crisis interventions or supports that were needed that were out of the scope of that link worker role. It could also be that the older adult wasn't willing to engage with the link worker, and we kind of had that drop off after the referral. So over the course of the next 2 years, we will be looking into that more to figure out how we can kind of decrease that drop off between the social prescription made and the older adults served. In this time as well, those regional projects have provided 49 presentations or trainings to social prescribing audiences. So that would be all of the healthcare providers. There's been 707 healthcare providers that have attended different trainings or kind of presentations in those 3 communities as well. And then just some high level kind of things that we've been hearing, because I know that the network coordinators from each of those regions are going to speak more to this, but staff are really seeing that the investment of time and relationship building is really resulting in older adults becoming more open to accessing those additional community-based supports. And staff are hearing from clients that they're feeling well supported and much more confident to live at home. And so over the course of the past year, we've really built out our evaluation framework so that we can really talk about the impact of this work. And so on the slide here are the 5 areas that we're focusing on for older adults themselves. And we're looking at to what extent our regional projects are making progress towards achieving these anticipated outcomes. So we're looking at whether or not older adults are reporting new or improved knowledge and skills from participating in this program, whether there is a change or stabilization of their self-reported mental and physical well-being, whether there is increased change or stabilization in how content they are with their connections, whether or not they experience improving or stabilization in their quality of life, and then whether or not they report that they are in control of the decisions that impact their lives as they age. And so one of the things that I think is really interesting with these outcomes is that we're not just always looking at improvements. I think stabilization in a lot of cases is also a really important outcome to measure. And so that's one of the things that we'll be looking at. We then have our outcomes for the service providers. And so this would be either service providers in community-based organizations or service providers in the healthcare system. And so we want to see that over the course of the next few years that there's an increase in the number of unique clients receiving social prescriptions, increase in the number of primary care providers making social prescriptions as well. And then those service providers are reporting an increased capacity to support older adults and an increased kind of improved sense of competence and confidence to meet the client needs as well. And then this more so for the health system. Relationships between partners have improved. As well, the referral pathways that people are using are improving as well, and that there's increased data sharing between community-based organizations and the health system. We're also looking at things like reduction in non-medical primary care visits, older adults reporting that they've reduced their frequency of visits to the emergency room, as well as hospital admission and decreased length of stay if they have been admitted. And then the final one there is just looking at whether or not service providers are able to kind of increase their capacity to collect and report on the information and the impact that they're having on their clients as well. So I want to switch gears a little bit from talking about evaluation to the link worker role, because one of the things that we heard from folks was that this link worker role in community was a really relational role. And when we were recruiting for that type of role, it was really about finding the right fit and someone that really understood the approach of social prescribing. So we wanted to develop some more on-the-job training that could be done when a link worker started their role. And earlier this year, we did some engagement across the sector to figure out what those core competencies would be for the link worker role and to make sure that they were validated. And so these were the 5 areas that we heard that would be really important for competencies. So the first one around making connections, it's really around that client relationship building, being able to build trust with clients and work collaboratively with them. being able to make relationships with other community partners as well. The second one around listening is this is making sure that the link worker is able to assess client needs and engage in ongoing follow-up with clients, and really make sure that they're listening to their concerns and also listening to the goals that they have as well. The advocating one there is around being able to communicate the value of the link worker role, as well as advocating for clients and advocating for themselves in terms of knowing their boundaries and when they need to access higher levels of support that's kind of out of scope for that link worker role. Navigating, that's around the service navigation that occurs in this type of work, as well as the care planning and the skills needed to kind of address the needs. And then the final one around self-reflection is making sure that link worker is able to kind of reflect on their practice and the support that they're giving to clients, and also their personal bias that they might have, making sure that they're creating supportive relationships. So there's a 5-module e-curriculum that we've developed that's open to link workers in the 10 communities that we're working with, but we've also opened it up to the rest of the sector as well. And so since we published it in July, we've had over 85 people register to take the curriculum. And so these are the 5 modules there. And in our results of the curriculum, the people that have completed it, we're seeing the competencies increase. So that first competency there around understanding the link worker functions and their role in the broader ecosystem, people are reporting that their competencies in that area have gone from 28% for taking the training to 76% after. The second one there around understanding equity-based approaches to care, that competency is increased from 44% to 80%. And then the third one of understanding how to build community connections to support clients has gone from 36 to 64%. So it's really positive that we're seeing those kind of results from this training curriculum, because it's a really great resource for the entire sector to kind of have as a training opportunity. So just a few more stats from the training curriculum. 88% of people that have taken the course have agreed that the topics covered were relevant and useful to their role. And 85% have indicated that they were confident or very confident in their ability to apply the knowledge and skills from the training in their practice. I'm going to skip this slide because I'm a little bit behind on time, but I just wanted to let people know that we are also tied into the Canadian Institute for Social Prescribing. And so Healthy Aging Alberta has been working with the Canadian Institute on a national level for the past year as well, to make sure that our voice is kind of being heard at that national level around the work that they're doing to advocate for more investment in this space. So our phase 2 communities have just started kind of very early on in their work in October of this year. And so these communities were selected due to their readiness for social prescribing. So there was already some existing momentum, again, around social prescribing, the concept. They already had some good partnership development in their communities with healthcare system teams and other community providers as well. And so these phase 2 communities were working in Jasper, Whitecourt, Sylvan Lake, Innisfail, Red Deer County, Wheatland County, and Vulcan. So what can you do? Because I know that's why a lot of people are here today. And I just wanted to say the 10 communities that we're working in, we really want to demonstrate the value of this model in a very intentional way to build evidence and facilitate future investment in social prescribing. And so we only had so much funding, right, to distribute out into communities. And we really wanted to go where there was already some of that momentum, given that we only have a 3-year timeline to really kind of build out this model and refine the model in order for it to be kind of scaled and spread in other areas. And our goal as Healthy Aging Alberta is to facilitate future investment in this space. We want to see this approach and that link worker role in every single community across the province, supporting older adults. And so if you're looking for actions right now and you want to start building connections and collaborations in your community between health, housing, and other community-based organizations, Healthy Aging Alberta would love to support you in doing that so that there is some kind of readiness to kind of move on a social prescribing approach if future funding does become available. And so my suggestion would be to reach out to your regional community developer, and we'll have some information about that in the email that we send out after the webinar. If you have existing funding already in your community or resources that you would like to direct to social prescribing work and you want support in doing that, you can reach out to me. We're really building a network here, and we want to be able to share the tools and resources that we're developing with communities across the province. And then another key action, if you're wanting to see this approach really take over Alberta and be a key support for older adults, then act as a champion for this type of work and speak to potential funders and provincial and municipal government representatives about the value of this work if you really want to see it in your community. We have some key messages that we can share with you as well, and we're always happy to talk. So I am going to leave it there, and I'm going to pass it over to Krista to talk a little bit about what's been happening in Edmonton.
Thanks, Beth. All right, bear with me as I just screen share here, everyone. So the Edmonton project really began its referral pathway in mid-February. And since we launched the new referral pathway from February to September 30th, we've received over 450 referrals. To date, we've been really working with home care, home living, transition services, hospital discharge teams, PCN clinics, and other healthcare providers in hopes to continue expanding referral sources and to continue to connect with those who see value in social prescribing and what it has to offer both older adults, healthcare professionals, and community serving organizations. So we have received referrals from over 270 unique healthcare providers during this time. And you can see on the pie chart just on the right, the majority of those referrals at 48% are coming directly from home care and home living. We also are receiving about 19% directly from hospital and another 9% from PCNs. During the first year, we've really assessed that the highest need for services in the Edmonton area have been around navigation of community supports and services, food security, housekeeping, assisted transportation, housing, and recreation and leisure. And while we're super excited about the positive response from healthcare teams, it also has led to some challenges. So we've as you can see with the 450 referrals, the volume of referrals continues to challenge the capacity of our project staff. We have a relatively small team, and similarly, you'll see, I think, in Lethbridge and Calgary, that we're really seeing many of our referrals to the project as a high complexity of client needs, which also really adds to the challenge around staff capacity. But that being said, it's really given our project partnership just this incredible time to flourish. So with the Edmonton project, we have the Edmonton Seniors Coordinating Council, Sage Seniors Association, Jewish Family Services, the Multicultural Health Workers, Drive Happiness, and our newest partners, Edmonton Meals on Wheels and Caregivers Alberta. And so the project partners have the opportunity to really get to know one another and better understand how all of the organizations can provide unique services to the clients that we offer those services to. And the formal referral pathway has been developed so that healthcare professionals can refer into the project. So it's given us that time to get to know one another, but just recognizing that those types of things do take time as we start to develop project partnerships. And so while we've been working with healthcare teams to understand when social prescribing would best meet the needs of their clients and patients, we really have more work to do on understanding everybody's fit within the project. So in Edmonton, we have made about 18 direct presentations to healthcare providers in which there was approximately about 520 providers in attendance. And a huge thank you to all of those who have helped to distribute our referral form and FAQ documents for healthcare providers. We've been able to provide that information to approximately 2,400 healthcare providers here in Edmonton. And so the project really has provided in some ways a challenge for link workers to connect to these essential services, especially where we've identified that there's appropriate essential services that are missing. So especially around things like housing right now, we know that housing across the city of Edmonton continues to be a challenge. We recognize that there's a need for additional hoarding supports, as well as mental health needs and some crisis management. So the project has really highlighted some of those gaps in areas in which we're finding a challenge to connect seniors to those services. And we'll be continuing to work with healthcare teams to just further identify where social prescribing is a best fit for their clients and patients, as well as just trying to understand how health and community can work together and just understand the roles that we all play in the wellness of older adults that we work with. And so we have developed, sorry about that. We have developed an FAQ for both senior centers as well as for healthcare providers. So those are available on our website for anyone who's interested. And for healthcare providers, we've also developed a pamphlet for clients as to what happens after a social prescription has been made. And so we recognize that one of the challenges of this project is also that we want to ensure that there's multiple pathways for clients to enter outreach services. And so social prescribing being that direct link from healthcare providers, we wanted them to have a tool to help their clients understand what happens with them after a social prescription is made. So we're very excited about, as we kind of move into year 2 and year 3, about the potentials that we have to grow and expand our project to support more and more clients and get them connected to those essential services they need. So we're excited to welcome all of the new projects that are coming on board. I know that we have lots to learn from one another, and I'm just so thankful that we've had both Megan in Calgary, Heather in Lethbridge, and Beth over at Healthy Aging Alberta, just really supporting all of the work being done. And in Edmonton, we're also really grateful to the government of Alberta for their support in the project as well, and the funding that we've received from the government of Alberta as well. So with that, I will pass it on to the next person. I think it was Megan.
Thank you so much, Krista. Yeah, go ahead, Megan. I know you have some slides to share as well.
Okay, I'll unmute myself. Okay. Hi, everybody. My name is Megan Hinks. I'm the network coordinator here in Calgary. And so the project here in Calgary, we have called the Aging and Community Support Program, not to be confused with Aging and Community Supports with Healthy Aging Alberta. Okay, let's see. Why aren't you going forward? Okay, there we go. So I'll give you a little bit of background about our program. So our program is in partnership with the WAYN Network. So the WAYN Network, if you don't know, is a collaboration of 4 agencies: Jewish Family Service, Calgary Seniors Resource Society, CARIA, and Calgary Chinese Elderly Citizens Association, so CCECA. This network has over 10 years of experience providing in-home supported referrals and case management services for older adults across Calgary. Our team connects with older adults in their own homes and in convenient community locations. So since 2022, the WAYN Network has been working on a project that includes a collaboration between the WAYN agencies, primary care networks, and Alberta Health Services here in the Calgary zone. Building on the strength of the WAYN collaboration, the project aims to improve the integration of health and community-based senior services. The focus is on improving coordination of non-health related services that support healthy aging in community and enhance the quality of life for seniors here in Calgary. And in 2022, the Aging and Community Support Program transitioned to join the Social Prescribing Initiative here in Alberta with Healthy Aging Alberta. So here is our year 1 successes. So we received 205 referrals from healthcare professionals for individuals in the community. Majority of our referrals came from the PCN, as well as our acute care sites, as you can see in the little graph on the left. So the PCNs here in Calgary zone have continued to be very positive about the project and the opportunity to refer to our program. In presentations to the PCN and acute care leaders, we have heard repeatedly expressed that there's a need for this type of project and program, and indicated that supporting older adults in the community was a strategic priority for their organizations. We developed the diversity role worker here in Calgary, and on intake, our intake surveys, it indicated that 17% of participants identified as a visible minority, and 21% of participants did not provide an answer. So this will be important for us to monitor going into our next year and the years to come with the project, to determine if there are efforts of the diversity worker to establish referral pathways with non-mainstream health service groups increases the referrals of diverse older adults in our community. And then in addition, we developed our own community of practice here with our frontline staff to support with training and to help support with the complex case management that we are seeing. So due to the complexity of the clients and emerging issues, training for staff is an important component that the network is committed to provide for our staff. We were able to offer training in mental health and addictions, harm reduction, and trauma-informed practice, including a supervision training for our supervisors. Now, with a few years of experience within this area of work, we've identified the skills and knowledge and experience required for this role and have been able to hire strategically to reduce staff turnover and burnout. I will skip my success story because I think we're short on time. No, we're not. We're good. I can say it. Okay. All right. Get ready. So the aging in communities, this is a success story or a positive story about the impact in our community. The Aging in Community Supports Program received, or ACEs, received a referral from the primary care network social worker for Joseph when he was unable to pay for his diabetes medication. Upon further assessment, the ACEs program outreach worker identified that Joseph had been unable to pay for his rent for a number of months and had a significant bank overdraft. As a result of the mistakes on some forms, Joseph was not receiving any of his entitled pensions since his retirement 2 years earlier. With no natural supports here in Calgary, and Joseph having limited English language skills, the outreach worker initiated bringing in an interpreter from the local language line. The outreach worker worked closely with the pharmacy to ensure that Joseph was able to acquire his medication through an emergency fund until his pensions were available through the Alberta Seniors Finance Assistance Program. They were able to connect him to Nation Vision to receive free eyeglasses. Joseph and the outreach worker navigated the form issues with Service Canada and completed the landing papers to successfully have Joseph receive a retroactive payment and his ongoing monthly payment started. With the retroactive payments, Joseph was able to pay off his overdraft and missed rental payments. Further, the outreach worker was able to support Joseph to move into a home that better met his needs. The dedicated and dynamic multidisciplinary team helped Joseph to start a new chapter in his life. Receiving the monthly pension payments and moving into a new space meant that he was able to save up enough money to go back to his home country, where he married his longtime partner, and together they are working to bring her to Canada. That story is just so beautiful. Okay. Oops. Challenges. So with a new program, of course, there's challenges, learnings, and gaps that we noticed. So one of the challenges is that we are seeing high complexity and high acuity of referrals, including health issues, mental health issues, and addictions. So with these high complex and multiple presenting issues, multiple barriers or risk factors, and service requirements across multiple systems, there's lots of complexity in supporting these individuals. This complexity has contributed to longer service times than we normally see in our other weigh-in outreach program, and collaborative service approaches and increased risk for crisis interventions. Due to the complexity of the clients and emerging issues, we've committed to providing training for our staff which is an important component to reduce staff turnover and burnout. We've experimented in regards to turnover and burnout with different staffing models to spread the demands across of the complexity across of the caseloads across the network. We've had some varying success with implementing the link worker position within our outreach roles. Some agencies have had success in utilizing this role to support participants, while others have struggled. The provincial work to develop a link worker job description and curriculum has brought more clarity for the role within the project, and the agencies are currently hiring for this position. So building and maintaining our referral pathways remains a challenge, mostly due to staff turnover at these sites, which requires continuous presentations and information sessions about our program and referral processes. Moving forward, we're identifying other possible referral opportunities, including AHS Transition Services here in Calgary and the Community Paramedic Program as well. We want to ensure that we are a part of the conversation of resources available when someone is going to be discharged into independent community living. Calgary also continues to have a strong support of our PCNs in our region, and we are committed to continuing and expanding and maintaining our referral pathways. Some of the other learnings and gaps that we've noticed was that there are safety considerations for our staff. So employee safety concerns continue to be monitored. Hazards such as unstable mental health, unsanitary living conditions, and unknown residents in the same home as our clients are some safety concerns that have kind of popped up. Hazard assessment protocols are regularly followed, and a 2-person visit is also encouraged when there is some safety concerns identified. There are also services for, or gaps in services for age 55 to 65. We've noticed that there's limited income supports, housing options, resources, and benefits for this age group, although they are facing age-related issues, are possibly functionally geriatric, and have multiple risk factors for psychosocial, mental health, or addiction issues similar to those 65 and over. The system capacity to accept referrals is also a challenge. For example, there are long wait times for community resources, including essential transportation, friendly visiting programs, and also mental health and addiction support for those older adults. Now on to the positives, excitement for year 2. So we're excited to expand our program by expanding our staff to support the growing referral pathways here in Calgary. We're excited to utilize the link worker role to help support our outreach teams and the older adults here connected to their communities. We're excited to expand and support the current referral pathways that we have and look forward to expanding into other areas in the health system. One of the other exciting things is that we're connecting with other community-based services in Calgary to help support our older adult clients. For example, we're connecting with the shelter systems because we have a lot of referrals for older adults who are vicariously housed and may come in contact with that system. We're excited to continue our participation in the provincial community of practice and see how we can further align to support the development and expansion of social prescribing in Alberta, including assessment tools, evaluation tools, and the best practices for this project. The addition of the new communities to the social prescribing program is exciting, and we're looking forward to working alongside them and to support the sustainability of social prescribing here in Alberta. And then that's my contact info if you want to hear more about Calgary.
Thank you so much, Megan. And we will share all of the contact information for the speakers today in the email that we send out after the session too. And so I will pass it over to Heather from Lethbridge. Oh, Heather, I think you're still muted. I can see you talk. Yeah.
Yes, that's right. 2 clicks. My name's Heather. I'm the network coordinator for the Lethbridge community. I didn't come with a slide deck. My discussion is more about how we started working prior to becoming a partner with Social Prescribing and being onboarded as one of the first communities of selection. And then talking through a little bit about the successes and challenges that we've experienced. So for those of you who don't know, our community social prescribing model is a partnership of social service agencies that are specifically delivering services to older adults. So that includes Lethbridge Housing, Norbridge Senior Center, Lethbridge Senior Citizens Organization, and Lethbridge Family Services. So each of those partners has a different stake in the supports that are delivered to seniors. And prior to social prescribing becoming social prescribing in our world, there was conversations about working collaboratively with within our own means to make sure that we were supporting people as consistently and successfully as possible. So our first kind of work around getting ourselves prepared was really working within our own organizations to understand what everybody's capacities were, what they could offer to a partnership, and then really developing a way of working. So how are our support workers receiving files? How are we divvying out the work? And so it really developed into a centralized pathway where anybody that's seeking services for a person over the age of 60, that's our program mandate threshold, contacts one number, and then needs are kind of distributed to the team based on that model. So like Beth mentioned, a lot of the communities that were initially picked were selected because they did have partners with health agencies, and they were doing a lot of supports for people to augment what healthcare service providers were doing. So that's kind of where some of that preliminary work that we had done just in trying to be creative in our own community was helpful in showing us that we were already aligning with best practices and kind of what social prescribing in our province was looking towards being. So success wise for our program, I would say the biggest thing is the ability for the workers to actually spend time in people's homes, in their environments. I think unfortunately in the healthcare setting, a lot of visits to doctors, clinics, hospitals, they're all inpatient, they're all clinical settings, and that's not necessarily the place to have in-depth, meaningful conversations. And so having the social prescribing program and having our team set up the way it is, we can really engage with people and have in-depth, meaningful conversations about isolation and connections and some of the barriers around that. So building that trust-based relationship and taking that time to have those conversations. And then really getting to see what people are experiencing in their homes. So again, sometimes what they report to healthcare providers isn't necessarily inclusive of really everything that's going on. And so being able to kind of be the eyes and ears for a healthcare professional or a team, it has been really well received. And some of our regular service provider referral sources are appreciative and know that that's a support that our team can offer. The other thing is the way we've built our program. Our kind of hub of the organizations that I mentioned is located in the senior center where all of our in-home supports and additional resources for older adults exist. So within our very small office space, we house Meals on Wheels, we house subsidized housekeeping, we house Drive Happiness, volunteer opportunities. So it really allows in Lethbridge, our team is called Navigators, but equivalent to link workers. It really allows the navigators to be in real time with some of the other services that might have a wait list or might need additional paperwork. So kind of overcoming some of those, like Megan mentioned in her example of somebody's paperwork not being filled out properly and not knowing that and resulting in their benefits being impacted. It really improves communication. If there is an error on something that's required for an in-home support program, that navigator can be informed immediately and kind of take care of that. So that's been really successful in linking people and increasing their interest in trying things. They may not have been interested in Meals on Wheels, but with the navigator being right beside the Meals on Wheels worker and maybe even bringing a meal if that's what that might mean, to kind of help with that acceptance piece, that's been a really important part. The other thing that we've received back from the healthcare professionals that have become consistent referral sources is the pathway to provide information back. So I think we all intend to keep people informed about the work that's being done, but sometimes your work gets a little overwhelming and you forget to provide feedback or kind of a closure summary. So we have developed something, and that was based on feedback from one of the primary care clinics that we've been working with. It's really developing what do healthcare professionals need, how frequent do they need that, what can that look like, and so we've created a formal pathway for that. So that helps ensure that there is that consistent communication back to the physician and the team that's taking care of them in the clinical setting. Some of the challenges that we have experienced since formalizing as a social prescribing program is really getting in front of groups of healthcare professionals. I'd say it's been pretty tough slugging getting invited to a staff meeting, getting invited to present, and then having a robust room full of people ready to hear what you have to say. I think healthcare professionals have a lot of things coming at them. Lots of things are happening on the side of their desk. So it's been tough to get in front of a big group of people and pitch what it is that we're doing and how we're doing it. So what that's looked like is more one-on-one conversations, and then word of mouth spreading within the teams when there has been successful work done and successful partnerships. It was mentioned already by both of my colleagues that file complexities increased. So it's really difficult sometimes to get to the more lighter touch issues like isolation, social connection, and some of those valuable pieces of information and connection for people, because they are experiencing financial crisis, housing, eviction possibilities, just an inability to kind of navigate the amount of changes or complexities that are coming at them. So that creates a demand on the workers that we have. Now we have wait lists, so it's hard to accommodate a wide range of things coming at us when obviously people may benefit from social isolation tactics and strategies and programs, but they're really having to focus on kind of the basic necessities of life in order to kind of get themselves going. So that's where we're finding a lot of our work is being, or a lot of our efforts is being put. Also, I'd say another challenge would be just having a shared understanding of what is and what isn't social prescribing. I think, and I know that's coming in a lot of the work that's being done and being developed by Healthy Aging Alberta, so that the messaging on, what healthcare providers can expect, what is something that they can refer for, what isn't something that they can refer for, and that consistent messaging I think would be valuable. So we kind of get soup to nuts in terms of the referrals that come in and try our best to get them connected to somewhere else or support them with whatever it is that they're presenting with. Finally, with future state, I think the ball's rolling. I feel like the ball's rolling in our community, and we have a lot of consistent programs that know what we do, appreciate what we do, and also are willing to kind of fill some of the gaps of things that we can't do. So that's been really great, and I think that will become more and more common. We're pretty much it for the main service providers for community-based seniors in terms of where people are turning for supports. And so, like Megan had mentioned too, building those partnerships with other agencies such as the shelter and some of the more crisis-based resources has been really where we've spent a lot of time recently, just to kind of establish a pathway of how far we can take somebody and then what we might need to be doing collaboratively to make sure that that person continues to be supported. I think for myself, I think having worked in healthcare for quite some time, there's never really been space for social determinants of health and the conversations that that takes. It's a medical model world in healthcare. So I really hope and see that the work being done by Healthy Aging Alberta and all of our programs is helping add to the opportunities and the options that healthcare providers have when there may be something, there likely is something different happening that is socially connected. And oftentimes we know some of the roots to unhealthy people do come down to social issues. So the fact that this is an intentional strategy to get people thinking about the social determinants of health within a medical model is really, it makes me hopeful that the conversations when you do go to your doctor will look a little bit different. And then I think too, being that we're not very far from Calgary, we do have a lot of people moving back Calgary, Lethbridge. So I like the idea of the consistency in a provincial model. So knowing that whether, a family member lives in Calgary and a parent lives in Lethbridge or vice versa, and people are seeking resources and trying to advocate for the supports that that may benefit them. I think knowing that we're all speaking the same language and trying to develop a program that regardless of if you live in a tiny town or a giant city, the foundation of what we're trying to do is a commonality. I think that's really important when we're trying to get people across our province supported consistently. The other thing that I'm looking forward to is Healthy Aging Alberta. Like you guys saw the video at the beginning of the session, all of those materials are super helpful to get out to people, not just healthcare providers, but also to the community so that they can advocate for themselves. So as those materials come out, I'm really appreciative of and trying to plug them places where people might not expect to see them, but at least it kind of normalizes the concept of having those conversations with your physician or with your healthcare team, and knowing that there's a resource at the other end of that. So that's everything for me.
So thank you so much, Heather. Now we're going to shift gears a little bit. So we heard from Krista and Megan, and Heather have been working on social prescribing now for a year or so. And as I was saying at the beginning, we've just introduced our phase 2 communities. And so I have 2 individuals, and they're going to kind of speak to the excitement of social prescribing in their community and what their vision is for the next few years. So we'll start with Ruth Mueller from Vulcan. And so Ruth, I'll let you share. I know you have some slides as well.
Thank you. All right. I'm Ruth Mueller. I'm a Community Development Coordinator with Alberta Health Services, and I work in Vulcan as one of the communities that I serve. And about 8 years ago, we formed a coalition of services, agencies, community people who wanted to improve and the health of Vulcan and bring health to Vulcan. And these agencies consisted of, and still do, Rainbow Literacy, FCSS, Health and Wellness Foundation, AHS with a dietitian, myself, the library, the town, community member, and there are others as well. And so about 5 years ago, this group realized that, or addressed the issue of there's a lot of people that go to the family physician that could really be supported with the services that are already located in Vulcan and that we could connect them with. But that is not happening. And one of the big reasons for that is that all of the physicians that work in Vulcan do not live in Vulcan. Most of them live in Calgary. We're thrilled that they come to Vulcan and that they serve the community. But one of the outcomes of that is that they don't know what is available in the community. Some of the other healthcare providers as well, the nurses also come from outside. Not all of them, but many come from outside of Vulcan. So as we noticed that disconnect, the communication disconnect, we decided to 5 years ago already, look into, we didn't know what to call it. Social prescribing, we learned about the UK, the work that was being done there. We spoke to several physicians, even in other communities, about the idea, and sort of started planting seeds within the medical community in Vulcan. At first, there was some reluctance for several different reasons, but the planting of seeds takes time, and that's what we had. Is we had time. And like I said, that process took us about 5 years. And then when we learned last spring that Alberta Healthy Aging Alberta is supporting social prescribing in Edmonton, Calgary, Lethbridge, we thought, we really need to be a part of this. And that's what started the ball rolling. And we're so grateful that we were chosen as one of the 7 communities. Thank you so much for that. So with our implementation, we are starting slow because it's a new program. We're going to start with accepting referrals for patients that are attending the medical community. So from any healthcare provider within the medical clinic, I should say. Our plan is to have a document addressing the social determinants of health that will be given by to every patient. We've chosen the age 50 and over. There's many reasons for that in Vulcan, but so every patient 50 and over will be given this document by the medical office assistant, and that person in the waiting room or later on in the exam room, where they can check off the areas that they would like to have some support in, if any. The doctor receives that form and discusses that with the patient, and if he or she sees this as an appropriate referral, we'll make the referral to our link worker. Our link worker has office space right in the clinic. And because it's a small community, there's not a lot of physical distance between the medical community and FCSS, Rainbow Literacy, all these other agencies that do exist in the community. Once we have started with the medical clinic and see that our pathways are working, with the referral and the meeting of the patient, meeting with the patient, helping the patient set up a plan, and then feedback to the physician. We then will expand it to the ER. The ER and the medical clinic are all under one roof. And the same physicians that see the patients in the medical clinic are the ones that also see patients in ER. And then there's also a clinic for attached to the if patients come to the ER because they have no physician, and there's quite a number of residents that do not have a physician in Vulcan, as throughout Alberta, then they are brought to a clinic that is a walk-in clinic, but not associated with the ER, so that the cost for Alberta Health Services goes down for that. And those patients will then be given that sheet as well to self-identify needs that address social determinants of health, and those so that we're also able to serve those without a medical home, because our concern was if we're addressing only the medical clinic patients, we'd be missing out on a lot of others that would need that support. Once that is going, then we will plan to expand it to home care, and once that is going, then also to other pharmacies and other senior service agencies. Let me just see here. I'm just trying to, there we go. What we are, our vision is to build trust, that in the next year or two that we have trust built at various levels. And Beth has already addressed this, but we're very specific, or very intentional, I should say, to do this. The trust between the link worker with the senior, the link worker and the physicians, the link worker and community assets, and also the link worker and the Act for Health Coalition. That is going to be key, and we know that building trust takes time and good communication and awareness of the issues before they become big. Also building trust, the seniors with the link worker, the seniors with the community assets, and also the trust that the Act for Health Coalition has with the physicians, community assets, and link workers. And you can see how that all ties together, but we realize that, or recognize that the trust is a major factor. We also, our other vision is to build capacity for the senior so that they are more aware of the supports available in their community, and that the seniors are also receiving the supports that they find helpful. We want to build capacity for the physicians. We know that there's a lot of stress on physicians, that there's a lot of patients that are trying to get appointments with physicians and unable to. So we want the physicians to feel supported by the community, and that would happen through Act for Health and the other agencies involved. The physicians building capacity as they witness the increased health or maintaining their health with in their patients. Also, recruitment of physicians into rural communities, as you are probably aware, is often difficult. And we see this as a good recruitment tool. When the physicians that are considering coming to Vulcan hear about this, we hope that that is an attractive thing. Build capacity for community services as they receive data about identified needs. They obviously will not receive specific data, but in general, that we would be able to provide them for. They would have the demonstrated collaboration for their funders, and also opportunities for volunteering. As we all have this conversation in a more public way, we hope that volunteering will also increase.
Natalie, line 101. Natalie, line 101.
I'm sorry, I'm in a medical facility. Also build capacity for the community at large, strong relationships, increased volunteer sector, and possible increase in the services and gaps that are identified. And the other build capacity is that the link worker position be fully funded, and sustainability depends on that. And we're already looking at what is possible within Vulcan. What can we, what other partners can we pull into this in order to sustain what we're doing here? And that is it.
Awesome. Thank you so much, Ruth. And then our last speaker, I will pass it over to Dixie, who is with us from Innisfail.
Perfect. Thanks to everyone who has spoken so far. And Ruth, you guys have a great vision and plan there. So I'm Dixie McLeod with McMahon Central in Innisfail, and we are starting with the phase 2 one-time funding for social prescribing. A little bit of a history, I guess, on Innisfail is that they've been a pretty progressive community as far as supports for their seniors through the years. They developed or founded the Community Partners in Action a few years ago, which is sort of a society of multiple different organizations, the town, PCN, AHS, home care, to name a few, who have been, I think working, very hard to move forward and enhance services for seniors in the community. We're very excited to have social prescribing and to get started with that. We do have our staff in place, our referral form developed, which has went to the medical home, and then our link and outreach worker have been hitting the pavement the last few days, chatting with pharmacists and other regulated health professionals to get the information out. I think vision wise is really just to enhance the services that are there and be able to connect our seniors with that system navigation, which seems to be definitely a tricky one for some, and especially with so many just rural and what I would say to be fairly isolated seniors in the community. Innisfail has a higher seniors population than the national average, and over 80% are still in their homes. And so, I think that that really there's just a hope to get moving and get going, and hopeful that referrals will start to kind of fly in soon. We had our asset mapping with Healthy Aging Alberta and PolicyWise just the week before last, and that was a fantastic day. And so I think that just looking forward to sort of building on that and moving forward.
So thank you so much, Dixie.
And I need to say thank you to Heather, Beth, because she sent me some forms so I didn't have to reinvent the wheel. So thanks, Heather.
That's what we like to hear. Awesome. It seems we've got a lot of time for questions. I know there's a few that have come in the chat already, so I can start with those ones. And so this question was specifically for Krista, or anyone else that wants to jump in. And it was, how do the project staff prevent scope creep and manage boundaries? What are the do, don't, and boundaries of a supported referral? So Krista, I'll let you jump in first, and then if Megan and Heather want to share some of their information from their communities as well.
Yeah, I think one of the things that we really tried to build into the Edmonton project was just support for that link worker role in a social prescribing case manager who is a registered healthcare professional. So sometimes there is kind of that unclarity of who is best going to support that client. And I think in terms of when that happens, it really is that the link worker is there to also help support that case manager role. And so they work together as a team to really help support that client, even in an overall encompassing way. One of the things we realized early on in the project is that when the referrals are coming into our centralized intake, we have a centralized intake at Sage Seniors Association in which all of our referrals go directly to. And from there, Sage does a quick assessment look at what partner would best meet the needs of those clients. And so during that process, we recognized that need for that quick assessment maybe is not best done by a link worker, because sometimes it is hard to identify when there are those complex needs. And so building in more of that registered professional in that quick assessment has been really beneficial, and that's something we're looking at moving more towards in the upcoming phase of the project, is having that person who's kind of triaging, for lack of better words, where that referral will be best met, just having that little bit extended scope of practice as a registered healthcare professional is going to be more crucial moving forward. I don't know, Megan.
Registered healthcare professional, you mean social worker, just to clarify.
Yeah, at this point, yes, a social worker.
But that social worker is still employed by a community-based organization. They're not necessarily embedded in the healthcare system. I just wanted to clarify that.
No, that's great. Thanks, Beth. I appreciate that.
I can jump in.
Oh, perfect. Thanks,
Yeah,
Heather.
sure. I can jump in because that's very similar to how we do it as well. We have one person that is a registered social worker doing an assessment of kind of acuity based on what the presenting needs are and what collaborative information she might have had to collect in order to take that referral in. And then files are distributed based on that. So, and we do have the luxury of having a pretty diverse team. So, and the ability to match people's needs with the staff that we have, their skill set. So that's been really successful, and not necessarily being kind of used to be the quadrant of the city. That's the support person you got. But the vision was a little bit different for us this time, and just matching people's needs with the skill sets and strengths of the staff that we have on board. So.
Thanks, Heather. Megan, I don't know if you wanted to share anything else.
We're both, our program here is similar to both Lethbridge and Edmonton in that we do have a centralized intake, and the assessments are done by a registered social worker. And then those intakes are distributed to the agency based off of the geographical area. So it's a bit different in that the worker is assigned the case. However, if the case doesn't fit with the skill set of the worker, then it would be distributed to a different agency who has that skill or capacity to provide support. Most of our referrals are coming from PCN and from acute care, so they don't provide case management for their clients. So the scope creep between health and our program doesn't happen quite often, but as we're expanding into other areas, that's probably going to be an ongoing conversation to kind of understand where our boundaries are for the program and what we can provide for clients and what other healthcare professionals are providing.
That's perfect. Thank you all. There's another question here. How long do you have funding for this program? So all of those 10 communities that Healthy Aging Alberta is supporting have funding until September 30th, 2025. So an additional 2 years. And so one thing I should have mentioned, so the funding through Healthy Aging Alberta is being supported by an anonymous trust. And this trust has been investing in social prescribing work across the country as well. So they're funding some work in BC and Ontario, and more recently Manitoba and Saskatchewan as well. And so they're really invested in seeing how social prescribing can grow and develop at more of a provincial scale and up to a national scale as well. But with the understanding that this type of work should not be funded by philanthropy in the long term. And so one of their big goals is to make sure that there is sustainable investment from government partners. And we are already seeing that in some of the programs as well. So the work in Edmonton and Calgary is also being supported in part by the government of Alberta. And in Lethbridge, FCSS has invested some more resources into their program as well. And I think we'll start to see that in some of those 7 new communities as well, to have kind of that matching funding for this type of work. And just seeing that continue to expand. So while our funding right now only goes to September 2025, I think we're already seeing seeds being planted and investment from government partners as well, which is really, really reassuring to see. Next question here in the chat, and I do not know the answer to this one, so I will let any of those regional network coordinators jump in. It's what is the overlap, if any, with First Link dementia referrals?
I can just speak to what I know the First Link workers to be. And I would say that there isn't duplication necessarily because the link workers are intended to, do home visits and, attend appointments and do advocacy work. And so I don't know the link workers or the First Link workers through Alzheimer's Society to do that type of work, but I could be wrong.
Thank you for that. I was just looking for, I guess, confirmation that the doctors who are using the First Link might refer to both, like understanding that there are different resources between what an Alzheimer's Society link worker and what a community link worker would provide.
It's the word link that's a good point.
Okay, so the next question here I have is around what, if any, are the eligibility criteria for service? I think we already touched on that a little bit. It's a little bit different in each of the regional projects. Some are 50 plus, some are 55 plus. And so that's really the only eligibility kind of defining piece around how someone would access the service. And then the second part with that question was, what are the specific capacity gaps in addressing the needs of those who are members of ethnocultural minority communities? So I'll let the network coordinators respond to that.
Sure.
Perfect. Thanks, Heather.
Yeah, no problem. So that is one of the partners that we're working to establish a relationship with. we have multiple different cultures in Lethbridge, and definitely know we're not the experts there, but trying to work alongside our LFS Immigration Services for their expertise and our expertise together. So that was a conversation that I had with their executive director a couple of months ago, and it's now being filtered down to all of their different programs for me to do some education on what our program can do alongside them.
Awesome. I don't know, Krista or Megan, if you had anything to share as well.
Yeah, in terms of supporting ethnocultural seniors, we're very fortunate here in Edmonton to have multicultural health brokers as one of our partners, and they serve over 2,000 families each year with diverse cultural, ethnocultural needs. And so they've been working with us to kind of better understand what ethnocultural supports are available across the city of Edmonton and how to connect clients with those resources. But just recognizing that a lot of times those circumstances are very complex. Perhaps those clients are coming in from different circumstances where maybe there's some trauma that has happened in their life. Perhaps they're coming in and aren't entitled, coming to Canada and don't have any entitlement to any benefits. And so we're just recognizing that there are really unique challenges with those clients, and that that takes a significant amount of time and efforts to get people connected to those resources, especially when those resources in community are very, very limited, especially in some of those smaller ethnocultural communities where those systems aren't as robust, or those supports just aren't as robust for clients. And so we're really, really grateful both to have Jewish Family Services and the multicultural health brokers who serve a variety of ethnocultures across the city of Edmonton.
Yeah, and here in Calgary, we have our staff is quite diverse in across the board. And one of our agencies, Calgary Seniors Resource Society, works in Northeast Calgary, which has a lot more diverse populations and communities. So they work quite frequently in connecting older adults to their community that's really close by. In addition, we have Jewish Family Service, who provides support for Russian speaking, Jewish speaking, or Hebrew speaking, sorry, across the board, across the city. And then we have Chinese, Calgary Chinese Citizens Elderly Association that provides language specific services for Mandarin and Cantonese as well.
Awesome. Thanks, Megan and Krista and Heather, for responding to that. There's a few more questions that hopefully I can answer. So there's one from Jaylene. Can someone self-refer, so client to link worker, which would skip over the healthcare provider? And so our response to that is not right now. We're really trying to focus on that intentional link between healthcare and community services to really build that evidence pathway around that formal connection. I think and the reason for that is because we know that a lot of older adults do seek help through their healthcare provider for those kind of non-medical needs, and they're not connected into any of those community-based supports and resources. And so the goal of this program, as it's kind of framed out right now, is to really build that intentional link and get those older adults connected into those community-based services to reduce the amount of inappropriate kind of medical visits that are for kind of social needs. So trying to kind of reduce that burden on the healthcare system as well, as we're really trying to build out this model. But hopefully in the future, and I think we've seen this in the UK, there are now elements of like self-referral into social prescribing programs. And so I would love to see it grow into that in the future. But right now we're trying to be very intentional about making that link between the medical and non-medical sectors. There's another question here from Wendy, just saying, high needs seniors require lots of resources and time. How can we serve those with less intensive needs through social prescribing? And I can provide my response to this, and anyone else can jump in as well. But I think we are still serving those with less intensive needs through our social prescribing programs. As we're saying, there's not necessarily any strict eligibility criteria that are only focusing on those high need supports. And it is supposed to be kind of a spectrum. When we look at social prescribing, there are some clients that might just need some lighter touches and referrals into community-based supports like Meals on Wheels or connection with assisted transportation or information about recreational and social programs. they might only meet with a link worker 2 to 3 times, and they feel like they have more capacity and they're empowered to maybe make those connections themselves. And so I would say in our programs right now, we are serving those with less intensive needs. I think if we're able to grow the capacity for that link worker role, we'll be able to do a lot more, and we'll start to see more of those referrals coming from healthcare providers for older adults that do have those less intensive needs as well, and maybe able to address more of that kind of social connectedness and social isolation. So I don't know if anyone else wants to jump in on that question either. So the other question that we have here that's interesting, it's a big long paragraph, so I'm going to try and pick out the question here. It's around, have you reviewed technologies that can help you with navigation in your location? Do you think it would be helpful for increasing your capacity and reach to available supports within the community? And absolutely, I think it would be very helpful if there's technology platforms that kind of help with some of that kind of service navigation for that link worker role and for frontline providers. I think things look a little bit different across the province in terms of the supports and services that people have access to. 211 is a great tool that is being leveraged in all of our regional projects, but the capacity of 211 also varies across the province as well. So that's another thing that we've heard. One thing that we've recently done with those 7 new communities is we've conducted some asset mapping workshops in all 7 of those communities, and our asset mapping was framed around the determinants of healthy aging. And so the link workers and other frontline staff in those 7 new communities will have an asset mapping tool that they're able to kind of use throughout the course of their work. I wouldn't say that that's necessarily a technology piece, but there's definitely lots of opportunities for us to kind of tap into different technologies as they become available. So we'd definitely be interested in connecting more about that, Nicola, if that's something that, if that's something that AHS is looking at.
Thanks, I'll connect.
So any last questions before we wrap things up, or anything that we've missed? Awesome. Well, we will be sharing out the recording of this session. And if there's any questions that you have for myself or any of the network coordinators in either the phase 1 communities that have already been doing this for a year or so, or the new communities that are just getting started, we'll also have the contact information of those network coordinators in that email as well. Everyone is very friendly and always happy to receive an email with questions. So please do reach out. We're really hoping that social prescribing will continue to be a collaborative approach across the province that we can really see grow and flourish in Alberta to support older adults. So really appreciate you all being here today. Hopefully you found it helpful, and enjoy the rest of your Thursday.